My name is Morgan Perrin, and this is my physical assessment video for NR 509.
My name is Dex Sadler, and I consent to the recording and submission of this video to Chamberlain University.
Okay. And then I will do an environment scan of the room. Okay, I will start the assessment by examining the patient's face and head. The face, there's no abnormal lesions or abnormal discolorations. The head is a normal size. It is symmetric and in a midline position. And then next I will palpate the lymph nodes, starting with the pre-auricular in front of the ear, and then the post-auricular behind the ear, the occipital lymph nodes behind the head, and then the tonsillar lymph nodes, and then down the jawline, the submandibular lymph nodes, and then the submental lymph nodes under the chin, and then the anterior cervical lymph nodes, the posterior cervical lymph nodes, and then the supraclavicular lymph nodes right above the clavicles. And then did you have any tenderness there?
No.
Okay. I did not feel any enlargements, and the patient denies any tenderness. And then next I will assess cranial nerve number 5, which is the trigeminal nerve. It has a motor and sensory component. So starting with the motor component, I will place my hands over the masseter muscles and have the patient clench his jaw. Okay. I did not feel any distortions, and he has great strength bilaterally. And then the sensory portion of cranial nerve number 5, the trigeminal nerve, I will have the patient close his eyes, and then you just let me know where you feel my touch.
Forehead, left cheek, chin, nose, right cheek.
Okay. He identified all of those areas correctly, so cranial nerve number 5 is intact. And then next would be cranial nerve number 7, which is the facial nerve. So for this, I will ask the patient to do a series of facial expressions, starting with a smile, and then a frown. Raise your eyebrows, puff out your cheeks, and then pucker your lips. Good. All of those facial expressions were symmetrical bilaterally. So next I will palpate the temporomandibular joint, or the TMJ, and then I will have the patient open his mouth and close his mouth. Good. And I did not feel any subluxation, any crepitus, or clicking there. Next, I will assess the patient's ears, first by just looking at them. The ears are symmetrical. I don't see any nodules or lesions. And then I will examine the ears with the otoscope, pulling the ear back. Looking at the external auditory canal, I don't see any drainage or swelling or cerumen. The tympanic membrane is a pearly gray with no effusion. And we'll do the other ear. The tympanic membrane, the external auditory canal, I don't see any redness or swelling or drainage or cerumen. The tympanic membrane is a pearly gray with no effusion. Then I will palpate the pinna on both ears. Do you have any tenderness there?
No.
Good. I don't feel any nodules, and the patient doesn't report any tenderness. Next, I will palpate the tragus on both sides. Do you have any tenderness there?
No.
Okay. No tenderness there, and I don't feel any nodules. And then next, I will assess cranial nerve number 8, which is the acoustic nerve. And then for that, I will do a whisper hearing test. So I'll have you cover your right ear, and then you just repeat the words that I whisper to you.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 4, 5, 6.
And then he identified those words correctly, so hearing is intact bilaterally. Next, I will assess the patient's eyes, starting with the conjunctiva. Looking at the conjunctiva, there's no, I don't see any lesions or drainage. It's pink and moist in color. The sclera is clear and white. And then next I will assess cranial nerve number 2, which is the optic nerve. First covering a pupillary response to light. So I'm getting my light source, and Dex, you just look straight ahead at me. And the pupil constricts. Okay. Pupils are about 2 millimeters in size and equally responsive to light. And then staying on cranial nerve number 2, which also covers central vision, I will use the Snellen eye pocket chart, and I'm going to stand at 6 feet away from the patient. Okay. I'm going to have you cover one eye and then just read the lowest line possible.
LTFPH.
Now cover your other eye.
LTFPH.
And then both eyes uncovered.
LTFPH.
Okay, good, and you can stay standing. So all of the letters were identified correctly, so the patient has 20/20 vision in the left eye, right eye, and both eyes. And then we are still on cranial nerve number 2, the optic nerve, which also covers peripheral vision. So I'll have you just stand facing me with eye to eye level. Okay, and then can you see my hands right now?
No.
Okay, just let me know when you do.
No.
Okay, can you see my hands now?
No.
Let me know when you do.
No.
Okay, and then can you see them now?
No.
Let me know when you do.
No.
Okay, good. Patient has good peripheral vision, and then you can sit back down. And then next I will palpate the patient's sinuses, starting with the frontal sinuses, and you just let me know if you have any tenderness. And then the maxillary sinuses. Okay. The patient doesn't report any tenderness there. And then back to the eyes, I will be assessing cranial nerves number 3, 4, and 6. Cranial nerve number 3 is the oculomotor. Cranial nerve number 4 is the trochlear, and cranial nerve number 6 is the abducens, and they control the extraocular movements of the eye. So to do this, I'm going to have you just follow my finger with your eyes only, and I'm making an H pattern with my finger, and I'm watching the patient's gaze. Okay, good. All EOMs are intact there. Next, I will move on to the patient's nose, and it is symmetrical. There's no obvious fracture or obstruction. There's no swelling. And then I will get my light source. Tip your nose up with my thumb here. The turbinates are pink and moist. Now looking at the septum, it is straight with no deviation. And I'll do the same on the other side. Turbinates are pink and moist. The septum is straight with no deviation. Next, I will move on to the patient's mouth, starting with the lips. I see that they are pink and moist. And then I'm going to examine the patient's teeth, if you'll open your mouth. Okay. There's no cracks or obvious signs of decay. And then if you'll open your mouth. Looking at the gums, they are pink and moist. There's no bleeding or swelling. The buccal mucosa is pink and moist. The upper soft and hard palates are pink and moist. The posterior pharynx, pink and moist with no postnasal drainage. The tongue is pink and smooth and moist. Then if you will lift your tongue up, okay. Looking at the floor of the mouth, it is pink and moist with no lesions noted. Okay, and then you put your tongue open up again. Okay. Dex does have his tonsils, which are midline. I don't see any redness or swelling. I would grade them at a 2+, which is normal, and they are midline. Okay. Cranial nerve number 9 is the glossopharyngeal nerve, which is the gag reflex, and we will not be assessing that for this video. But cranial nerve number 10 is the vagus nerve. So for that, I'll have the patient open his mouth and say ah.
Ah.
Good. The soft palate and uvula rises symmetrically with phonation. And then cranial nerve number 12 is the hypoglossal nerve. So for that, I'm going to have you stick your tongue out and then move it left to right. Good. And then next I will assess cranial nerve number 11, which is the spinal accessory nerve. So for that, I will place my hands on the patient's shoulders and then apply resistance and ask him to shrug his shoulders. Good. That was performed well. Next, I'm examining the patient's neck, which is symmetrical. There's no obvious deformities. I will palpate the trachea. And that's midline. Next, I will palpate the thyroid gland. Swallow. We'll do the same on the other side. Swallow. Good. I didn't feel any nodules or enlargements there. Next, I will palpate the carotid arteries one at a time. Good. They are 2+ and bounding bilaterally. Next, I will auscultate the carotid arteries using the bell of my stethoscope. And then I'm going to have you take a breath and hold it in while I listen. Okay, and I'll do the same on the other side. Take a breath and hold it in. Good. And I did not hear any bruits bilaterally. Next, I will check range of motion in the patient's neck. Starting with flexion, I'll have you tuck your chin to your chest. Okay, and then look up at the ceiling for extension. Good. Look over your right shoulder and now your left shoulder. Good. That was rotation. And then put your ear to your right shoulder, ear to your left shoulder. Good. That was lateral flexion, and the patient has good range of motion in his neck. Next, I will assess the patient's chest, and just by looking at it, there's no obvious deformities. The chest is symmetrical. I will auscultate the heart sounds, starting with the diaphragm of my stethoscope. Listening at the aortic area, which is the second intercostal space on the right sternal border. Pulmonic area, second intercostal space, left sternal border. Erb's point, third intercostal space, left sternal border. Tricuspid, fourth intercostal space, left sternal border. And then the mitral area, which is the fifth intercostal space, the midclavicular line. And then I will repeat those areas with the bell of my stethoscope. Aortic area, pulmonic area, Erb's point, tricuspid area, and mitral area. And I did not hear any abnormal heart sounds. Next, I will auscultate the patient's lungs, starting with the anterior lung fields. Take a breath in. Breath sounds were present and clear in all areas. And then I will have you stand up with your back towards the camera so I can assess the posterior lung fields. Take a breath. Good. Breath sounds were present and clear in all areas. You can sit back. Next, I will assess the patient's hands. Just have them like that. Yep, I'm looking at the finger joints. I don't see any redness or swelling or deformities. I don't see any nodules. And then I will check capillary refill on one finger for each hand. I'm holding the nail bed down till the fingernail turns white. And that is a capillary refill of less than 3 seconds. Both nail beds went back to a healthy pink in less than 3 seconds. And then I will assess grip strength by having the patient squeeze my hands. Tight. Good. Grip strength is 5 out of 5 bilaterally. And then next I will check your radial pulses if you'll just. Okay. And they are 2+ bilaterally. And then next I will check cerebellar coordination by having the patient perform 2 rapid alternating movement tests. So starting with your hands face down on your thighs, if you'll turn them with your palms up, and then now repeat that and increase the speed. Okay, good. And then the next test would be take your index finger to your thumb, and then your middle finger, 4th finger, 5th finger. Now increase the speed and repeat that. Good. Both of those were performed well and well coordinated. Next, I will assess next, I will assess range of motion in the elbow, and for this video, range of motion will only be performed unilaterally. In a true assessment, I would be performing range of motion bilaterally. So starting with on the elbow for flexion and then extension, good. And then I will perform range of motion for the shoulder. So starting with extension, and then flexion, internal rotation, external rotation, and then abduction and adduction. Okay? The patient has good range of motion in his shoulder there. And then next I will test bicep and tricep strength. So if you'll just flex your elbows like this, and then pull against my resistance. Good. Now push against me. Good. Strength is 5 out of 5 bilaterally for the biceps and the triceps. And then next I will be assessing the deep tendon reflexes. And then I will only be assessing these unilaterally. So starting with the bicep reflex, I'm going to support his arm on mine, and I've got my thumb in the antecubital fossa area, and I will strike my thumbnail with the pointy end of the hammer. Okay, and he had brisk response there. And then for the patellar reflex, I will strike the patellar with the flat end of the hammer. Good, he had good response there. and then also the Achilles. I'm gonna have you relax your foot, and then I will dorsiflex the foot and strike the Achilles with the flat end of my hammer as well. Okay, and he had good response there. Next, I will move on to the abdominal exam. So if you can lay down. I'm gonna move the camera here. Okay. And then I will expose the patient's abdomen some. And then I'm starting with inspection, looking at the contours and the symmetry. The abdomen is flat and symmetrical. Going to auscultate the abdomen in all 4 quadrants. Bowel sounds are present and normoactive in all 4 quadrants. Next, I will auscultate using the bell of my stethoscope, and I'm auscultating for any bruits, starting with the aortic artery, which is midline above the umbilicus. And then the renal artery, starting with the right renal, which is lateral and above the umbilicus. The left renal artery, above and lateral to the umbilicus. And now the iliac arteries, the left iliac artery, which is below and lateral the umbilicus. And then the right iliac artery, which is lateral and below the umbilicus. And I did not hear any bruits in any of those 5 areas. Next, I will palpate in all 4 quadrants, and then you let me know if you feel any tenderness. Okay. The patient doesn't report any tenderness, and I did not feel any masses. Next, I will percuss in all 4 quadrants. We are percussing for any flatness, dullness, or tympany, and I did not hear any abnormal sounds. Next, I will assess for Bloomberg sign. So by doing that, I'm going to hold my hand at a 90-degree angle, and I will press into the abdomen, and then we are assessing for any rebound tenderness as I pull my hand out. The patient doesn't report any tenderness, so that would be a negative Bloomberg sign. And then next, I will palpate the liver. I'm going to put my left hand on the back, and then I'm looking for the edge of the rib cage here. And then I'm going to have you take a deep breath, and then I'm feeling deeper and upward. Good. And I might feel the edge of the liver, and then if you'll come towards me some, or roll towards me some. And then looking for the edge of the rib cage. Take a deep breath. Okay. And I did not feel the spleen, which is a normal finding. Okay. Next, I'm looking at the bilateral lower extremities. I don't see any abnormal discolorations or edema. I will check bilateral dorsalis pedal pulses. And they are 2+ bilaterally. Next, I will check range of motion at the knee. And again, we're only doing this unilaterally. Starting with flexion and extension. Good. And then we will assess range of motion at the hip. So I'm going to flex the knee, which flexes the hip. So starting with internal rotation and external rotation, and then abduction and adduction. Good. So he has good range of motion there. And then next I will assess bilateral knee strength. So if you'll pull your knees up towards you, then you can raise them up. And then pull against my resistance. Good. And then push. Good. He has a 5 out of 5 strength bilaterally at the knees. And then now I will assess range of motion at the ankle, starting with dorsiflexing the foot, plantar flexing, and then rotation. So he has good range of motion at the ankles. And then I will assess strength at the bilateral ankles. So if you'll, we're going to dorsiflex it against my resistance. Okay, and then push. Good. Strength at the bilateral strength is 5 out of 5 at the ankles. Okay, and then for this part you can stand back up. I'm going to move back over here. Okay, so for this test, this is the Romberg's test. I will have the patient just stand with his eyes closed, and we would do this for about 20 seconds, and we're looking for any swaying as he's standing there. I don't see any, so that would be a negative Romberg. Okay, and then the next test we will assess range of motion at the spine. So starting with flexion, bend over and touch your toes. Good. And now lean backwards, looking up at the ceiling. Good. And then kind of twist to the one side and then twist to the other. Good. So that's rotation. And then bend at the hips like this. Yep. And then the other side. Okay. And that was lateral flexion. So he's got good range of motion with the spine. And then if you'll just take a few steps forward and then a few steps back. He's got an even, steady gait that is normal. And then next I will assess the spine. So if you just want to spin around, I'm palpating the spine for any masses, tenderness, and expected curvatures. Okay, good. And I didn't feel any masses, and the patient denied any tenderness there. So that would conclude my physical assessment.